So to start with, again, our job first is to do no harm. That's the principle of any surgery. We must be patient-centric. The principle has to be that if we cannot benefit the patient, we must not at least cause any harm. Adhesion prevention strategies in hysteroscopic surgery is what my talk is going to be. Predominantly, it is a fertility preserving surgery most often in most cases, unless we are doing a TCRE or other surgeries for menorrhagia. The simplest surgery which causes the least amount of damage is that of a polyp, wherein you can use either a scissor or you could just do a simple resection using a loop, and now we must see to it that most of us resort to bipolar surgery. The second surgery which we look at is that of a septum. Again, a very, very rewarding surgery. This is a patient who had 9 previous abortions, who came to us all the way from Jabalpur, and surprisingly nobody did either a 3D or a HSG on this patient. And again, here the principle would be whether you would use electrosurgery or you would use a scissor. So there are some studies that say that scissor is better than electrosurgery. However, we predominantly use the bipolar loop to do most of our surgeries. Here, of course, we are using the scissor. Sometimes, if the septum is very large, we may need to resort to electrosurgery. As you can see, this classical flattened uterus, which should give you the idea that this could be a septum. A loop electrode is what takes hardly about 5 or 10 minutes to perform this procedure. You could be surprised sometimes in a patient with adhesions where you will have a patient who says that her Mirena has failed, and you would be surprised to see that an ultrasound was not done, and you will see a proper myoma sitting in front of the LNG, intrauterine device. So simple myomectomy needs to be done to improve your success rate. And lastly, a second trimester abortion. Patient had secondary infertility, and we could see some fetal bones on ultrasound, which we had to remove before she conceived. So Asherman syndrome, the condition was first described by Heinrich Friedrich in 1894, and then further characterized by Joseph Asherman. A little deep look into the history. It is also known as Friedrich syndrome or Friedrich-Asherman syndrome. They started talking about the first case in 1894, and then Asherman in 1948 did a study of about 29 cases. Definition of intrauterine adhesions are bands of fibrous tissue that form in the endometrial cavity and often in response to a uterine procedure. They are commonly treated with hysteroscopic resection using a scissor and hormones subsequently. The different grades of intrauterine adhesions, as you can see here, different classifications. We don't want to get into those. The challenges that we face when we do a procedure like this: prevention, causes, surgical plan, and adhesion barriers. How do we prevent adhesions? Effective contraception so that we have less number of unintended pregnancies, use of medical methods to reduce the frequency, use of MVA if we do a surgical evacuation, and in case of chronic RPOCs, use hysteroscopy. Treatment plan: hysteroscopy with fluoroscopic control, IUD with hormonal medication. After that, for 6 weeks and a second look, hysteroscopy. This is what was recommended way back by the Asherman's Expertise Center, a lovely website which I got to see because of this presentation. The IAGE practice report clearly states that the type of hysteroscopic procedure being performed may also impact healing and determine subsequent formation of IUAs. So prospective evaluation of hysteroscopic procedures report that the endometrium heals fastest in a polypectomy, slowest in a septoplasty. The lowest incidence of adhesion is following a polypectomy, and the highest rate of adhesion is after multiple fibroid resection. So these are points that we must keep in mind when we use adhesion barriers or we use hormones for subsequent wound healing. Prevention, again, procedures confined to the endometrium have the least adhesions. Those involving the myometrium with unopposing surfaces have the highest incidence. There is a recommendation that we must use a cold loop lesion removal rather than electrocautery. Lesser resection compared to greater resection. The cold techniques that is used, we'll come to that in a while, may not be appropriate for a vascular pathology because we may not be able to achieve hemostasis. The guidelines again, polypectomy, least adhesions, level B. The risk appears to be greater when electrosurgery is used versus blind um, removal of POCs. The application of an adhesion barrier following surgery that may lead to endometrial damage significantly reduces the development of adhesions. Level A. And this is Ivan Mazen, who spoke about cold loop hysteroscopic myomectomy. A Karl Storz device remove the endocavitary lesion by a slicing procedure using a monopolar current of 110 watts, then use the cold mechanical loop of Mason to disconnect connecting fibers between myoma and myometrium. After detachment of the intramural myoma becomes endocavitary, remove it by slicing again by using the monopolar electrode. Always cut action towards the notch of the myoma, not in the opposite direction. This is the study that said that they have lesser adhesions when it comes to using the cold electrode. If Dr. Prashant Mangeshkar is around, maybe he can comment on this because it's the Storz device. A second look laparoscopy is something that they can recommend to prevent adhesions, especially with extensive surgery. It should be recommended for all women undergoing hysteroscopic resection of myoma, polyps, or adhesions. We now come to adhesion barriers. It could be IODs with the copper when we remove the copper filament, an amnion graft, intrauterine Foley's, use of gels such as hyaluronic acid and polyethylene oxide. A randomized controlled trial comparing the efficacy of the balloon and the IUCD device of 201 cases, as you can see here, said that the heart-shaped intrauterine balloon and IOD had a similar efficacy to prevent adhesions. This is the heart-shaped balloon where we use a Foley's catheter and a heart-shaped IUCD. And another study which said that after transcervical resection of adhesions, amnion grafts is a very safe method than using injections of chitosan for recurrence of intraanal adhesions. Chitosan is a powder derived from shell of shrimps. This is what I wanted you all to see. This is again some literature search that we have done. This is also injected in the endometrial cavity to achieve adhesiolysis. This is a polysaccharide. Another important device is using hyaluronic acid gel for prevention. A study of 70 patients, the routine use of anti-adhesive agents such as hyaluronic acid in women who are due to undergo hysteroscopic myomectomy significantly reduces the risk of intrauterine adhesions. This is a type 2 FIGO procedure. Cellular therapy of the endometrium and update. Again, this is something new. In the stem cell, they think that when inflammation is there is an unbalanced repair breakdown, there is defective endometrium healing, either as a result of inflammation or infection causing adhesions. And that is why they recommend bone marrow stem cells to be injected in the myometrium to prevent further adhesions. And this is the conclusion of their study. A very recent study published in 2019. Cell therapy trials for the treatment of endometrial pathology have reported promising findings with demonstrable safety. Temporary amelioration of adhesions can be achieved with this particular procedure. This is another wonderful study as early as 2020, where aspirin has been used to prevent endometrial fibrosis by suppressing TGF-beta 1. This is the study. Transforming growth factor serves as a multifunctional cell regulator and used along with estrogen prevents adhesions. This study of about 58 patients, Group A, 4 mg of estradiol valorate for 21 days, followed by progesterone. Group B, 4 mg of estradiol plus 100 mg of aspirin for 21 days. 1 mg of cyproterone acetate was given in the last 10 days, and the patients were treated for about 2 months. And they found in Group B, where aspirin was used, preoperative length of the uterus to postoperative length went up, endometrial thickness from 4 to 7, duration of menstrual period from 2 to 5, menstrual volume from 31 ml to 63 ml, and postoperative adhesions, mild adhesions 3, moderate adhesions 2, severe adhesions 2. So there is a great success when aspirin was used to prevent the fibrosis. And finally, our good old estrogen and progesterone we use. We use estrogen first, or we can use conjugated equine estrogen of 4 milligrams estradiol twice a day for 30 days. In the last 10 days, we could add either medroxyprogesterone acetate or norethindrone in a dose of about 2.5. To end, this is a slide from Citibank, which I thought was extremely pertinent here. Even the smallest task requires caution. So we must exhibit caution when we are operating a patient who is in hysteroscopy, because we need to save our uterus. We need to see that we cause as less damage as possible. Stay safe. Keep your family, parents, and friends safe. Thank you.